That was great, Niels. And now welcome, Ran Lee. I think it's very nice again to see pulmonary critical care joining us because at the end of the day, we all live in the same thorax, right? So that's a quote from Eduardo Mireles, who was our program director. So now, Ran Lee, time to defend the undefendable, I would say.
Good morning, everyone. I'm Ran. I'm one of the critical care cardiologists at Cleveland Clinic. Thank you for allowing me to spend the next 10 minutes of your time arguing why I have the winning argument that traditional cardiology fellowship with an ICU focus is sufficient to practice in the modern day CICU. I thank the panelists, Dr. Katz, Dr. Senman, Dr. Germain. It's really nice to be on a stage with people I looked up to and inspired me to go into this field. But with that, I'll say that I am an ABIM certified critical care cardiologist and an advanced heart failure transplant LVAD cardiologist. I own it. I did the training. That makes me a certified expert to talk about what we're doing wrong. My other disclaimer is Neil Chasen was my program director and trained me. But the provocative question really is, did he need to? Sorry, Neil, I had a great time. Thank you for taking me. So my argument is that CICUs are best staffed with and by cardiovascular specialists, cardiologists. My other argument is that there are not enough critical care cardiologists to fill the need across the landscape of CICUs. You've heard that in the previous session, you've heard that now. I also think that cardiovascular medicine fellowship provides skills for the majority of our CICU patients, and I will show some data to back that up. And there does exist pathways to gain extra certification to practice in a critical care setting that I think we need to explore a little bit more. You've all seen this document from the C3TN authored by Dr. Bahula, Dr. Katz, and others, but my emphasis here is not going to be on the top line that you saw on previous arguments of respiratory insufficiency, but more of, well, guess what? It's still a cardiac ICU. We still have unstable arrhythmias, cardiogenic shock, mechanical circulatory support, hypotension. We also have a lot of mortality that comes from these different conditions, and who best to treat them than a board-certified cardiologist? Digging into that data a little bit more, Dr. Berg showed these slides, but you tally up the percentages of valvular heart disease, cardiac arrest, aortic syndromes, heart failure, cardiogenic shock, bread and butter ACS. We still are at a premium of cardiac-specific diagnosis in the CICU. Yes, the patients are sicker. I am not discounting that argument, but it's still a cardiac ICU, and they're going to be admitted to the ICU for cardiac issues. We actually do have data, thanks to Dr. Van Diepen in 2017, who ran a survey of 600 or so CICUs and looked at what is the staffing model in your current CICU. And I'm going to highlight the fact that there just are not enough CICU intensivists to keep up with the existing and growing demand. This was 2017. It's probably even worse now as patients are sicker. I also want to highlight the actual percentage of cardiologists that were in those units from a cardiac intensive care perspective, only 8% or so. There's no one way for extra training. It's like Epic. There's no one way to do something, so there's nothing that's efficient about it. If you look at summary of current training pathways in critical care cardiology and acute cardiovascular care, you have a bedrock of internal medicine, followed by either a pathway of critical care medicine, which takes about 2 years if you choose that alone, or cardiovascular medicine fellowship, which takes 3. And then you can subdivide into further specialties, heart failure, intervention, or you can do critical care medicine followed by cardiovascular medicine and get dual certified. But I want to point out to the bottom left of the screen where there's a suggestion of ABIM cardiovascular certification and training program, society-based critical care certification for individuals who have a specific focus in critical care, but are cardiologists first and foremost. There's opportunity and monetary costs to all of this. So this is a paradigm from Dr. Katz and Dr. Gage, who published about specifically heart failure physicians who wanted to practice in a cardiac ICU setting and how that would look like. And I want to draw emphasis on the fact that costs start accumulating. $1,430 for internal medicine residency, another $2,500 for general cardiology boards. If you chose heart failure specialty, another $3,000. Critical care medicine fellowship itself, sitting for those boards, $2,300, to lead to a whopping almost $10,000 in ABM certifications, not to count the $2,000 in annual fees. So there's opportunity and monetary cost at the expense of the trainee and the individual to go into a dedicated critical care cardiology pathway. So what does a reasonable path forward look like? I want to highlight something that limits that opportunity cost, that mitigates that trainee injury, financial burden, and burnout. And to what was made in the previous session, increase diversity and inclusivity in the workforce, promote faster and earlier entry to take care of critically ill individuals, and to equip those individuals with appropriate skill expansion. You've seen this slide by Neil in the previous session. What I want to highlight isn't so much of the mixing and matching of different pathways, but Dr. Sinha, who chaired this, really put this out into the ether, which is we can actually do clinical cardiology and do electives in CICU and other ICUs and get it done shorter and still practice in a CICU setting and still do a darn good job of it. Dr. Katz had this idea back in 2016 when he authored The Evolution and Maturation of Critical Care Cardiology, really highlighting the fact that, okay, level 1 and level 2 training in critical care cardiology does not require anything outside of cardiovascular medicine fellowship itself. And you can scale that up with more electives and more time in your ICUs. And Dr. Saras Valabajru, let's go to that anyways. Saras published this and said, well, not every level trained individual in CICUs need to work in a level 1 CICU. And you can cross-train your competencies with your complexities, where basic level 1 and level 2 trained cardiologists can operate in many CICUs across the country. This is a very busy slide that really just shows the fact that COCATS says the same. You look at the number of requirements for a majority of these skills, a bare minimum of 24 months is enough for the majority. What requires extra training? Well, the skill to place an intra-aortic balloon pump emergently, and I would say a lot of centers are referring that to interventional cardiologists if balloon pumps still exist in your center. Tony Carnicelli at MUSC and Dr. Katz published on how do we do certificates. Well, how do we focus our skills on airway and bronch and chest tubes in time during cardiology fellowship. And so you can round 2 weeks in an OR, you can do 8 weeks of elective time in a cardiothoracic ICU, you can attend didactics on ventilator core curriculum. So there are pathways out there to work with your institution to bolster your skills, which are necessary. And then the Society of Critical Care, the Critical Care Cardiology Education Symposium document that came out of University of Minnesota really highlighted, well, here are the core things that we need from a medical ICU and a cardiac ICU, and let's focus on that to create the centerpiece here, a critical care cardiologist that can do pretty much everything at the end of the day. So my argument and my summary is that cardiology fellowship is sufficient to deliver critical care services. The incidence of illness severity, comorbid conditions, and cardiovascular medical complexity still grows. I don't doubt that. Cardiologists need pathways to be able to equip themselves with the best tools to fight the coming battles while fulfilling the growing demand. And at the same time, we need to pay attention to workforce diversity, inclusion, and the ability to deliver rapid care at all levels of CICU. And most importantly, speaking as a critical care cardiologist, if we design a CICU-based curriculum for general cardiology fellowship with certification, we may benefit all parties, patients, the workforce, trainees, but we have to do it in a way that adds to what we already have. We don't supplant, but we supplement and complement what's already out there. And with that, I thank you.
Great counter-argument. Thank you for that, Ron. So I think it's very important for us to kind of understand what is the trainee perspective. And before we go into that, I'd like to kind of just by show of hands, how many trainees we have in the audience today? Fellows, residents, medical students, great. Program directors of pulmonary critical care or cardiology critical care? Okay, great. So because of that, let me start with Amanda, who is actually doing her third-year cardiology fellowship. It's going to be a critical care fellowship starting in July. What do you look into a program, and what's kind of the ideal scenario from your perspective at this stage that you would like to get in terms of skills and knowledge to practice as a critical care cardiologist?
Yeah, thank you so much, and thank you to all of you for being here and for having me. I'm already very inspired by what I've seen today, and I'll say that one of the quotes that sticks with me from this morning is that the patient is the captain of the ship, and as we've seen that we can't produce enough critical care cardiologists to take care of everybody. Just because we can't doesn't mean that we shouldn't find ways to. That's not a good enough reason for us not to figure out ways to get everybody the same access to high quality care. And I think that what I'm thinking about right now is that the same way we have hub and spoke models for cardiogenic shock care, we really should be thinking about a hub and spoke model for education in critical care cardiology. And when I think about myself and what it is that I wanted to pursue as a critical care cardiologist, I have a strong interest in medical education, and I think a lot about my role as being somebody who's going to be dual trained in cardiology and critical care, as being somebody who's going to help to, having exposure to both of those fields, being part of a pulmonary critical care division, be able to try to help understand and kind of provide the hub in that educational system and provide curriculum to help people both in general cardiology fellowships as well as non-cardiology ICU fellowships with curriculum that can help to provide this same kind of standard of cardiovascular critical care to all patients. And I will say that specifically one thing that really attracted me to the program at NYU and something that I'm really looking forward to next year is that I am going to be hired by the pulmonary care critical care division. I'm going to be a pulmonary critical care fellow in the teaching conferences alongside pulmonary critical care fellows. And one of the things that the program director, Dorina Drizzo-Harris, told me about prior people who've come through the program is that the fellows really, really benefit from learning from each other. And my educational experiences so far, I found that peer learning and peer teaching is so important that I'm really excited to get to give my case presentations during fellows conferences about topics that are specific to cardiology, to learn from them about the topics that they're kind of thinking about. And I think that having that hands-on direct exposure to being part of a pulmonary critical care division for the year is going to give me some of the tools and insights as to how are pulmonary critical care physicians thinking, how might I adapt into some of the mindsets and some of the cultures that may differ from my cardiology training, and how can I be part of that hub and spoke educational model to help develop further curricula and to be really a leader in the educational development of critical care cardiology.
Fantastic, thank you. Now let's look at this from the perspective of the program directors, because you have 1 year, particularly when many of us follow the pathway. Some others have done the 2 year. When you have 1 year, you have to squeeze in there the requirements to be able to sit for the boards, the skill sets that you need. And I think programs vary significantly from institution to institution. Like, Jim Horowitz, our program director at NYU, has put together a very nice curriculum that includes a rotation in cardiotoxicology, right? The toxidromes that we have to understand as cardiologists because we have a tremendously busy tox center. Nina, how do you think you need to craft those programs and adapt that over time when, you do your first year of training for the first critical care cardiology fellow, and then the next one comes and say, what do you learn from the first one to go to the second? How do you craft that and kind of try to match to the requirements and the trainee perspective, kind of like interest?
Yeah, so as Balim can attest, she is my fellow, and although I'm her program director here, I feel like she really is my boss running this conference. But as
we
Balim
all feel that way sometimes.
As Balim can attest, it's a very intense year. So pulmonary critical care is a 3-year-long fellowship, and we are condensing half of that, the critical care portion, into 1 year to train cardiologists. So this is a very action-packed year where they're doing nonstop ICU rotations through medical ICUs, but also through other ICUs, primarily cardiothoracic surgery, but also surgical. And the purpose is to learn all the things that you don't have already learned in a CICU during your cardiology training, primarily ventilator management, as well as MCS, depending on your institution. And just as I think Dr. Berg talked about in his last argument, you know, how you can't learn all the cardiac-specific skills, temp wires or PA caths in a weekend CME session. I also will say that you can't learn bronchoscopy skills, invasive mechanical ventilation, and all the things that surround management of mechanical ventilation in a 4-week elective as a only cardiology trained fellow. I think we've beaten it to death that people are living longer with more multi-organ failure, and people coming into CICUs have way more than just STEMIs. A lot of them are coming in with respiratory failure, needing invasive mechanical ventilation. And to trivialize that portion of management of the patient or to ignore it altogether is frankly dangerous and irresponsible, because we know the severe impact of invasive mechanical ventilation, sedation, paralysis on the patient, on their mortality, on their long-term outcomes. And I myself see these patients actually outside of the ICU, so I have a post-ICU clinic, so I see all the sequelae of people who have been on invasive mechanical ventilation, regardless of the cause, whether it's cardiac cause or primarily respiratory failure. So to condense all of that training for mechanical ventilation, bronchoscopy, all the other critical care specific skills into little electives for a three-year fellowship, I think really trivializes a very important morbidity that we have to deal with in this patient population.
I think those are excellent points, and it's also the challenge that every institution is going to be different. You know, the trainee might have an idea what they want to do, but you want to end up working in a place that might have different expectations. We always talk about, sure, the critical care cardiologists be able to serve in a cardiac intensive, in medical and surgical CVICU. And maybe directing this to Sean, who has experience in working in both, and also has been, you know, leading many of the educational and academic efforts in Canada. How do you see this path to get the trainees to, when they have to go and look for a job, and it might differ from what they learn? Should they continue to try to build on with mentorship from as a junior faculty? Should they try to get electives even through a critical care cardiology year, even if they might not have a particular interest or they don't know what is out there in the market?
That's a difficult question, and I think you have to tailor the answer to that to each individual institution, because each individual institution has their own practices and policies. Some may be like NYU, that they're very easy and willing to give people time in multiple units. Other centers may have a more segregated surgical unit or thoracic unit or medical units. So I think how you approach your application process, whether it's elective time or locum weeks or whatever that is, has to be tailored to the individual institution. I would like to go back to comment on some of the other skills and training, and I want to acknowledge that it's going to take some time to build a workforce and that of dual trained people. But what I don't think we should do is lower the standards of our training. We have to ask ourselves, are we aiming to train people that are comfortable, competent, or experts in this field and in cardiogenic shock and cardiac arrest? And as someone who's dual trained, I think many cardiologists who come through training are comfortable in parts of ICU care, just like many intensivists are comfortable in parts of critical care. But to gain the true expertise, that the type of expert that you want your family members cared for, it takes volume, it takes time, and it takes true cardiac training and dedicated ICU training. And I don't think this is sort of a weekender or a couple months. That might be sufficient for some smaller units that can be spoke centers. But to become a true expert, I don't think we can back off on the time component for training.
I was thinking, as you were talking, if you apply this to internal medicine, which I would argue the ABIM blueprint for internal medicine and critical care look very similar, that the internal medicine graduates would be, if they had a COCAT statement for internal medicine, they'd be COCAT's level 2. And the data is very clear that just because you have internal medicine training, there's a mortality benefit to being an expert in critical care, right? Why that would not apply to the CICU, where arguably you guys are doing some pretty phenomenal stuff. I was at ACC and I was like, this is really cool. And, you know, you can't just get internal medicine training and go be a cardiologist, right?
So piggyback into what Sean just mentioned and Neil, the workforce is going to take time. We probably, last year was 177 dual trained critical care cardiologists in the country. Maybe, let's say we're now to 179. Maybe a few more that are coming up from this conference. So, and the systems have to be adjusted or tailored accordingly. Innova has one of the most successful cardiac shock teams in the country, and they don't have critical care cardiologists, but they have one leader in the field, which is Dr. Sinha, and they have intensivists and with different backgrounds that work very closely with the cardiologists. So I would flip the coin, and we do it for our colleagues in pulmonary critical care. We have been talking again about the partnership, and how can we, is there going to be a pathway where pulmonary critical care fellows are going to say, I kind of like cardiology, but do they have 2-3 years of cardiology? Are we oversimplifying cardiology? I think that's probably not the right answer. Or do they have a specific pathways to learn MCS and hemodynamics? And if we flip the coin and say, that might not be enough for a cardiologist to learn vent management in a month, can they learn that in a month for MCS? Or maybe, Jason, you are the first leader of our society, and you've done also MCS management. How do you think we can embrace that?
Oh, I think there's a lot of work to do, clearly. And I think that the questions are interesting. I agree with Sean that we need to aim for excellence, right? You know, we can't aim for a lower target. But there are also, people have brought this up, and I think it's very pertinent. There's a realistic approach. Like, how do we get a qualified and passionate workforce to the bedside now when we need it? And there's so many patients. So, you know, the partnership, you know, with the pulmonary critical care medicine folks, our anesthesia critical care folks, standalone critical care, surgical critical care is so pivotal right now. I want to highlight, so we're going to have to ask Nina to come back next year, because Nina's not just talking the talk. Now she's going to be walking the walk. So Nina's going to be attending in the Duke Cardiac Intensive Care Unit coming up soon. And so she's going to have all sorts of new insights and perspectives on you know, what is unique, what is shared, what is opportunity, and where the education needs to focus. And so I think that will be clear.
I think it goes back to the very nice Venn diagrams that you put in many of your papers, Dave.
I think we have to be stewards of the entire healthcare system, though. I'm a critical care cardiologist, but two of my worries are cannibalizing pulmonary and critical care workforce and cannibalizing the heart failure workforce. So every person that I bring into this sphere who is a pulmonary and critical care doctor takes away from the care of pulmonary patients and critical care patients in our MICUs. And similarly, heart failure is a wonderful and robust specialty, and every person that we draw into our penumbra is a person who's not taking care of amyloid and diastolic heart failure in a different setting. So while I think we want to advocate for all of these pathways, I do think we have to be sensitive from our healthcare system as a whole, what's best and what's most important. I really think it's important that before we debate anything, we have a laser focus on what is the exact problem we're focusing on. And I think we're really just talking about level 1 CICUs and having that type of expertise there. When we have the graphs of level 2 and 3 CICUs, we're really conflating the problem, making it amenable to debate. But I don't think anybody on this stage or anybody in this conference is going to talk about needing 7 years of training to get there. We really need, it's a call for action for our society. We really need to define levels, phenotype them, and categorize them. Sean, in your paper, I think there were more than 600 entities that qualified as a CICU in America. But the amount of level 1 CICUs is probably a few dozen. So I just want us to, as an audience and as a profession, to be mindful of the external effects and the opportunity costs that we have when we're trying to deploy precious resources.
That's an excellent point. Thank you, Dave. So we have a couple of questions from the audience. Can you please introduce yourself?
Yes, Cameron Desfolian, Baylor College of Medicine. So I completely agreed with what Sean Van Dippen said, and I just want to add, we've talked a lot about respiratory failure as something we struggle with within cardiac ICUs. I think the other thing we've left out is brain injury. And managing brain injury and managing respiratory failure as an intensivist is something that takes constant kind of vigilance, tweaking the patient, looking at how your therapies respond, making changes. That's not something that lends well to just bringing in a pulmonologist once in the morning and having them leave and having that go well for the patient. And I think rather than talk about an ICU where we have a choice between an intensivist versus a critical care cardiologist, both of which I think are good choices. There's a lot of ICUs out there right now where it's a cardiologist with a palm consult once a day, or an intensivist with a cardiology consult once a day. I would much rather take the latter, because I think the intensivist on the cardiac questions can reach out to the cardiologist, whereas vice versa, it's not as easy when things are changing all the time with respiratory failure, shock, neurogenic issues, all the problems that really need a vigilance and training. And just like Sean said, that takes time and experience. It's not a very easy thing to teach.
I think I will add to that. It's an excellent point. The palliative care expertise as well, because general cardiologists are not great at that. Any comments on the later? So let's go to Rob.
Good morning. I'm Rob Roswell from Northwell Health, and just want to thank you for the conversation going on here. But I disagree with a lot of the conversations that are saying that we don't have enough critical care cardiologists working in our CICUs. We don't have enough dual boarded in critical care medicine and cardiology critical care cardiologists. But there's a whole swath of people who've been doing critical care cardiology in CICUs for 20 years. We don't know exactly what the number is for those people, but they also should be brought into the fold because they are the people who are actually working in level 1 CICUs. So when we're saying that we don't have enough critical care cardiologists, the question is, how many critical care cardiologists are there in the country who actually have the experience and the expertise, who have been doing these things in level 1 CICUs for decades on? And I think the other thing I would just quickly mention is when we're talking about training for critical care cardiologists, are we talking about training and educating those to work only in a CIC or a CVICU? Or are those training that they could be CVICU, SICU, MICU, all of those things? And I think that is another discussion that we should have. What is a critical care cardiologist? Where should they work? What unit? And just sort of dovetailing what Dave just mentioned about taking things away.
Yeah, I would just comment, I think those are all really important points. I think how we get to those numbers, understanding who's been practicing in that environment and who wants to stay and continue to practice in that environment is going to be very important for sort of defining our landscape, how we leverage the current workforce and how we build on that workforce moving forward. I will give just a single anecdote. When I was a young faculty member at the University of North Carolina, we ultimately went from a sort of a large open model of CICU care to a sort of a closed multidisciplinary care model. And people came up to me ahead of time, external stakeholders, and said, you're going to piss off a lot of cardiologists that practice in that cardiac ICU. You're going to contract the workforce to sort of a dedicated group. It wasn't dually boarded people. It was just people that were interested and passionate in the care of those patients and dedicated. But we were going to have to contract, and people were said, you're going to raise a storm here at UNC. They're going to want run you out early in your career. And so we did this, and we messaged this, and I didn't have a single comment like that. Only a lot of people who came up to me and said, thank God I don't have to practice in that unit anymore. I've been forced to practice in there for several years, for decades, and I don't feel comfortable taking care of patients with this type of complex critical illness. And so I think understanding who those people are, who are the ones that really have been dedicating their career and are passionate about that, and a number of them are our leaders and our educators. That's going to be something that collaboratively we're going to have to figure out, and it's going to be really important. I agree with you, Rob.
And then the last thing I just want to mention really quickly is that I think cardiology fellowship is flexible enough. There is that 24 clinical months, but in that last year, if you're a general cardiology fellow, if you do all of that in ICUs and CVICU, neurosurgical ICUs, CICUs, MICU, you are in effect training to be a critical care cardiologist. You won't be able to sit for critical care boards because of the administrative stuff, but you would have the clinical competency if you spent that whole year doing things that you would do in a critical care fellowship program. So
then why can't they sit for the boards?
That's a board difficult question, and so I'll just have a disclaimer. I'm on the board of directors of ABIM, and this is and so I have some knowledge of why this is.
Sorry.
I know you brought it out. It's fine. I'm in friendly territory here.
For sure.
So the reason that I don't think you can sit for it, because there's a strict rule that says you have to have 3 years of clinical training to sit for cardiovascular boards. And so that's the rule. And so if you want to combine heart failure with cardiology, you could do that extra year. EP, you could see the combined, process that way. It seems to really have a structural problem if you do 2 years of clinical cardiology and 1 year of critical care medicine and come out with 2 ABIM certificates versus someone who did clinical cardiology for 3 years and just has 1 certificate. So it's something we're trying to figure out, but that's an internal issue with the requirements there.
But certificates notwithstanding, that person is missing a whole lot of culture, training, oversight, education, and a holistic program, really making them an intensivist in spirit and algorithms and practice. I think Dr. Chasen and Dr. Chen would probably agree. I think there is a structural difference. I don't think you can make that up by popping in and not having a holistic curriculum really focused on building that physician skill set as an
Great
intensivist.
points, but let me.
So I think we have only 1 more minute. I want to make sure we get to the next question. But all great topics, all great things that have been also discussed in the AHA statement by Dr. Sinha.
David Barron, Cleveland Clinic, but Florida. So just briefly, I think that in response to the comment that, taking somebody from heart failure to critical care cardiology or taking them away from pulmonary looks at it the wrong way. They're really fundamentally different. The world of the internist, the intensivist is very different than the heart failure cardiologist. I, for one, love ICU, but I also love seeing the same patients for 10 and 15 years on and doing the outpatient work and so forth. So I think they're separate. Critical care cardiology is wonderful, and those that want to spend the 6 years and do that are largely folks who are going to be in ICUs all the time. There'll also be roles for people who do heart failure cardiology and transplant who desire that particular set of skills and seeing patients longitudinally. So, and I lastly would say that I applaud the effort to have the separate specialty. Right now there's 120. Eventually someday you'll be here and everybody in the room will be critical care cardiology. So I think it's really good, and the patient is in fact going to benefit. I remember years ago when I used to run ICU care and there were no intensivists where I was in New Jersey. Weren't involved, and you're right, we clearly missed a lot of things. So I applaud the specialty, but you don't have to worry. There's plenty of doctors to go around who will choose each kind of lifestyle, whether ICU medicine or outpatient or so forth. Thank you.
Thank you so much. And I think there's interest enough time. We're going to close here. Thank you to the panelists. Fantastic session, and everybody for the participation. And let's keep enjoying the meeting today. Thank you.